I'm really pleased to have this panel with us this morning. So it is my pleasure to introduce John Auerbach, who's the Senior Vice President of Public Health at ICF. And John is going to lead a distinguished panelist who they're going to introduce themselves here in a second, Jim, Arman, and Tabatha, to talk about public health workforce and AI from a practitioner's perspective. And I think this is very pertinent in our discussion as we prepare the next generation of public health practitioners and other public health professionals. What do they foresee? What do they portend as the skills that our students and graduates are going to need in the years ahead? So with that, I'm going to pass it off to John Auerbach. Thank you, John.
Thank you, and hello, everyone. I would just say a bit about my own background. I've spent 30 years working in public health. I was a local health officer for almost 10 years. I was state health commissioner for about 6 years, and I'd worked at CDC for a number of years. So really thinking concretely about what's the application, the availability of AI, the potential of AI in those settings, I think, for me and the other panelists, is a reality. And I think the picture, I think it's safe to say, is it's a complex and uneven picture because the public health field, practice field, is complex and uneven. So I think we're going to be talking about that, what the promise is, what the potential is, what the challenges have been, and in particular, we want to have a focus on what do we hope that the students that are being trained now will bring to the workforce when they complete their degrees and are getting hired in health departments around the country. We're going to start with introductions, and first just quick introductions, and then we're going to ask each of the panelists to give us a few minutes where they describe what's the current state of affairs with AI in their unit and sector. And then we're going to have a discussion among ourselves where I'm going to pose some questions and then the panelists will discuss those. And then we're going to try to have about 18 minutes of Q&A at the end. So as we're talking, if there are questions that you're thinking of, please plan on asking those when we get to that section of the discussion. So with that, let me ask each of you just quickly to introduce yourself and say what your job is, and then we'll go through a longer round of about 4 minutes each, telling us about the state of affairs.
John, thank you, and good morning, everyone. My name is Arman Latif, and it truly is a pleasure to be here with all of you today. I'm the Chief Information Officer for the Virginia Department of Health, and I look forward to the conversation that we're going to have about public health, AI, and workforce.
Thank you very much, John. It's a pleasure to be here. My name is Jim Borda, and I serve as the Fairfax County Health Department IT and Informatics Manager. It's a pleasure to be here and looking forward to the discussion. Thank you, John.
Great, thanks.
Hi, my name is Tabatha Offutt-Powell. I'm the Vice President of Public Health Data Modernization and Informatics at ASTO. It's the Association of State and Territorial Health Officials. It's a nonprofit organization. We work with a lot of our members, which are our chief health officials across the country, including territories and our freely associated states.
That's great. And, over the course of the last few years, I think I've interacted with each of your organizations as people have talked about AI and wanted to understand exactly what is this going to mean for us. So why don't we spend a few minutes with each of you letting us know where are you right now in terms of the adoption of AI, what's gone smoothly, what do you see as perhaps on the horizon? Want to start, Arman?
Sure. So let me start with a very simple fact. At VDH, there's no shortage of data. We have lots of them. When it comes to vaccinations, diseases, social determinants, environmental factors, we have all of them. The question is, what do we do with the data? Now, the data we have and the way we use it, it tells us the story about what has already happened. Yes, we can do trend analysis, we can measure outcomes, and we can display the information in nicely looking dashboards. But think for a second, that's past data. It has already happened. It is informative, but does it predict the future, right? And that's where the power of AI comes into play. And in public health, and one of the speakers had already mentioned this before, I think, Ed, you mentioned that, disease surveillance, right? Can we predict the next disease outbreak? Can we inform policies that will help with reduction of overdose deaths? Can we come up with ideas to improve maternal health, right? These are all information that's embedded in the data. We have to find it, and that's where AI can be very powerful. Now, we all know that there are different types of AI, from predictive to generative to NLP to RPA, and all of them are applicable in public health. With that comes that challenge of ethical dilemmas, bias, privacy concerns, and also workforce impact. In order to achieve that balance, there are really 3-4 things that comes into play. One is leadership, and fortunately for the state of Virginia, we have a really good commissioner who's very forward-thinking and is bringing AI to the front and center, which I'm very happy about as the Chief Information Officer. But you also have to worry about data governance. You also have to worry about data maturity. And the significant point that I'm going to make before I close is that AI is less of a tool, and it's more of a shift in mindset. And that, to me, is the message that the students and professors and the deans that you have to take away. At the Department of Health and other institutions that I've worked with, the tools exist, the skill sets are there, but it's a shift in mindset that's the most challenging part to make AI happen. Thank you.
Thank you. Jim.
Well, at the health department, there's a lot going on, and then there's also a lot of questions that are still popping up, because we're all aware of the changes and the fast pace that AI is bringing to the table here. So in our division at the health department, we are looking at establishing a foundation that will help serve as that solid ground to help our employees and our staff be able to move forward with what's happening. And in order to understand what we will be able to do with the data that's available to us, we'll have to basically have that solid foundation and framework. So as we look forward to the future and try to understand how we can harness the data that we're capturing and collecting at the health department, we'll have to educate and make sure that we are providing the staff and the personnel and everyone that is using AI the information that they need in a way that will be useful, meaningful, and safe. So right now, I think it's really a journey that we're starting on, and we're trying to figure out the best approach to get on that path forward. So it's really a matter of looking at it in a couple of ways. One, where do we want to be in the future in terms of understanding how we're going to help support the constituents of our community within the county? What do we want to do better? And then looking where we are now in terms of the data that we're collecting and how we're harnessing that, and how we are then going to move forward with this framework and foundation that I'm talking about that we're building. So it is a very fluid state right now where we are, because at the county, there is just the notion of, okay, I know it's a tool, and now I can start using this in a way, but people are still trying to understand, why am I even trying to use it? The big question mark is, how do I even leverage this tool to make myself more productive at work and to do the things that I want to do differently and better? And so we're trying to find a way forward to help solidify this governance and establish an easy way for staff and personnel to use the tools. while we still learn and adjust according to what we're seeing all around us, nationally and globally. So it's really a journey, and that's where we are right now.
Thanks. You've got the national perspective because
Yes.
you're looking at all 50 states. So what's your take on it?
So as we're looking across the country, we look to see what policies are being put in place related to AI in health departments. One of the things that we conduct, we just did this in 2025, we have some early results from our assessment where we look to see what was the adoption of AI policies across the country for the states and territories. And really about 70% of them said, yes, we have an AI policy in place, or we're in the process of developing one. And that was from last year. So that's going to change, right? It's a snapshot or snapshot in time. That is really something that's going to be moving. And as the jurisdictions are adopting these policies, those are going to be changing. I would say one of the things that we've seen is that the implementation of those policies and implementation of that, the operational guidance, that has, the adoption of the policies has driven, it's really faster than the ability for jurisdictions to be able to come up with these operational guidance. I think that's an area to operationalize the policy is really, really key. So as employees are wanting to do that or they're having questions around that, they really focus on some of those gaps that they see. And I think there are opportunities, right? So if you think about the use of some of these individual tools and also compared to taking an enterprise approach, the enterprise approach gives jurisdictions the ability to say, the health department has signed contracts with a company, a vendor, they have data use, they have other types of, like cybersecurity, they have all of these different, documents in place that they can put with that company that ensures that there's an enterprise approach to that. I would think from like an academic perspective, when you're thinking about, who's going to be in the workforce, I just wanted to highlight informatics specifically because we work with our Informatics Data Modernization Network, and those are informatics directors. There are some of the CIOs. There's our members that are data modernization directors that are working in public health agencies. That is a very, very small percentage of the entire public health, employment. Right? So when you see that they're a very small number of the composition of a public health department, what's really, really key among them are they're the liaisons between the programmatic staff that are working maternal and child health or infectious disease at B or in those other areas in public health. The informatics directors, the informatics team members are the ones that interface directly with the information technologists, with your IT departments, and that translator is really, really key. So they're seeing on the ground what's happening from a programmatic perspective, what the needs of the public health employees are and where they can benefit most from the technology and the use of potential for AI. But there's also, an opportunity to really support that workforce. So we're seeing training as being a significant need, the operationalization of the policies that are being implemented in jurisdictions, and also opportunity to translate what's happening, the research that's happening from academic institutions into actual public health practice. So those are the three things that we really wanted to highlight.
That's great. Thanks. A few years ago, when looking at where health departments, both local and state, were likely to begin to do direct work with AI, and that's work where they have some control over it, as contrasted with just receiving a database that others have utilized AI in developing. There were three areas that we saw most often, and so I'm going to ask are you seeing these three areas as the main places where people are thinking about working on AI? The first was communication. It was working on everything from translations to customizing materials to populations that had specific health issues. The second one was helping with routine, tedious administrative tasks that were repetitive and that most staff thought, please help me with these because that takes a lot of our time. Those included things like when you're changing a policy, getting public input, and you may get hundreds, sometimes thousands of comments, and using AI to sort of categorize those was one example. A third area was surveillance or epidemiology, where it was actually being used to forecast something in the future or to streamline access to epidemiological data so that you had either the ability to have access to the data more quickly or more granularly. So can you maybe just quickly, each of you say, are those areas that you've already begun to work in? Are there others where it's concretely now specifically on a regular basis folks are working with AI? Here I'm looking again at the things over which you've had control as contrasted with just when you're accessing a database from, say, CDC that has tapped AI forecasting within it.
I'll go first, if that's okay. Just really quick, John. One thing that I do want to highlight in regards to anything that we're doing right now at the county level is that we're always keeping the human factor center, right? It's the human element, it's the people, it's not the technology, but it is most importantly the people, the persons. That's what is making a difference. And for us, at the local level, because we are still in a very exploratory mode right now, we haven't actually gone live with anything into a live production mode. But to answer your question quickly, it's yes on the documentation piece, the administrative piece, in order to alleviate some of the burden. We are looking at ways to help streamline those processes and find the way to help people get information faster with these tools. And then in terms of communication, we absolutely want to have a way to bridge the gaps between us and the community and the constituents that we're serving, because that is definitely something of high importance. And again, it's the human-centric piece that I'm emphasizing. And then lastly, in terms of, of course, trying to do our best to, within our EPI department, to find ways in the future to be very on point in terms of the data elements and the pieces of information that we need in order to help protect our community and to help bridge the gaps in terms of communication, in terms of tracking the disease before it becomes a major outbreak. So doing those things faster, yes. So yes to all of those.
Thanks.
So at the state level, I think a point should be made that AI uses a lot of computing power, right? So now we're going to go a little technical. The state has to go through a transformation process in terms of its computing power, its infrastructure, the ability to ingest data. All these things have to be at a certain level before you can really think of AI. So we've spent a lot of time, we've invested a lot of money to go through that transformation process, to put the infrastructure in place where we're migrating from on-prem to cloud services, and also putting in the types of systems that capture the data, because we need to digitize processes before we can grab the data that AI tools can use. So that's number one. So that's been a big effort. Now, as we're doing that, there are little things that we did, like Copilot, for example. Very powerful. It's one of the most simplest tools, but it's very powerful in a workforce environment. We've had translation tools on our website that can translate into multiple languages. And we're looking at other simple things like note-taking, for example, right? So there are little tactical tools that are available that we are trying to incorporate into the state agency. The one challenge that we have when we talk about disease surveillance and the predictive capability, you have to take a strategic view. You can't just do it tactically. And when you take that strategic view, we do have a regulatory body in the state of Virginia called Virginia Information Technology Agency. So we have to go through their process, get their approval, and work with them. There's a COVRAM process, which basically requires permission. And so it's an involved process. We have started that in multiple fronts. And as we go through that process, on the other side, we have tools and infrastructure available to implement AI in a very large scale.
Thank you. Tabatha.
So John, I think you were completely on target with the results of the survey that we did. About 30 to 60% were saying, yes, we're using it. for content development, for administrative purposes, for those types of things, but a smaller percentage, around 10% or so, around the use for like disease surveillance and the such. And I think the most that we see in terms of technical assistance requests and things like that for support around data governance. A lot about the focus about how do we use the data, protect the data, what are the privacy aspects of that, I think are very important. And again, I'm trying to translate this into the academic perspective as well, is that I think that these multidisciplinary teams, sorry, I'm tied-tongued today, or whatever you call it, but I would say the multidisciplinary teams are really, really critical. So for those who've been in public health for many years, they're interested in the potential use, they may be concerned about it, different levels of excitement around the use of that. But I think as you have new graduates coming out from public health programs, what's really going to be informative is that insight, the fact that they're trained in methods to have that critical thinking, to see if I'm going to analyze data, what am I seeing that doesn't kind of add up in the analysis of those data? From an informatics perspective is how do we link the data to provide additional data insights? How do we exchange data with healthcare, for example, more efficiently, more seamlessly? And then how do we leverage things like health information exchanges or other types of intermediaries and shared services? Like all of those are really what are top of mind for data modernization initiatives now and also for informatics as a whole in terms of public health. So.
That's great. Well, maybe I want to focus a little bit on what are the challenges you have to overcome as you're doing this work. A few years ago, as I would talk to different folks at the local and state level, they'd list a bunch of things. They'd list concern with hallucinations, concern with bias, a concern with protecting private health information. That, I also heard a lot about loss of jobs. By the way, I used to say, don't worry about that. Now I say, yeah, it's something to worry about. But are those still the issues in your workforce, among the policymakers that might be funding you or trying to regulate whether you are using AI, or among the communities that you serve? What are the issues that you're hearing as you're moving ahead that you feel like you need to still pay attention to in terms of being able to then move ahead?
So the first one, and probably the most significant one, and I think I mentioned that at the beginning, it is a shift in mindset. Just like in project management, people go from the traditional way of running projects to the agile processes. There was a lot of pushback, why are we doing this? But once you get to it, it actually makes a lot of sense and it adds a lot of value. So it's a similar mindset shift. Most people don't ask about, what tool are you using, what technology are you going to use. They will talk about the ethical dilemmas and the bias, they're aware of it. But it's mostly a mindset shift, number one. And number two, yes, as Tabatha mentioned, that data governance becomes extremely important because, you have 2-3 sets of data and the AI tool can spit out certain results. It's not incorrect, but it may not be perfect in terms of exactly what you want. And when you add the fourth data set, it gives you a different interpretation, right? So you have to have that governance structure, the quality assurance processes, and whatever quality assurance process you have for a dashboard, multiply by that at least 2, and do the testing against the AI to make sure that it's spitting out the results you want before you release it to the public. So I think those are the two areas where I see most of the resistance.
Thanks.
Well, one of the things I was reflecting on, which not maybe kind of like tangentially related, but I think this reminds me back to when so in my previous position, I was state EPI and also chief over EPI health data and informatics in Delaware. And one of the things that I really recall is kind of in my mindset is how would this have been different if we had some of these other tools that we could leverage? Obviously, that wasn't an option back then, but I think there's still the need, for example, for epidemiologists and for informatics team members to really have that training where they can differentiate when you're looking at the data, when you have, to be able to interpret and to have those insights. And there's a lot of scrutiny in terms of when you have a pandemic or something like that on the actual numbers. That was something that was really, really key during that time. I think we would still have that same level of scrutiny to look and evaluate the data. We would be able to do things quickly, more seamlessly, but we would have an infrastructure and a framework that has these auditing tools, that has this ability to be able to assess what we're seeing and evaluate those types of models that would be put into place to ensure that we can make really informed decisions based off the data that we have and the systems we have in place. But we could see a future where all of this connectivity is happening. We still want we want public health professionals trained in the methods and the critical thinking skills to be able to evaluate the utility of those data. And just highlighting that every single data source has a limitation in and of itself. Assumptions for statistical modeling, all of those things, those still exist. We need to be transparently knowing what those are so that when we speak to the data or speak about the data, that we can be informed and communicate that effectively. So I think that was the key for me, is that we really have to lean into some of the technology. The other part, just to kind of highlight like a next step of that, is how does this public health sustain that, knowing that we have the limited resources? I don't know if you're going to get to this, but I'd love like colleagues here to really lean into that too, in terms of like how to address that. At ASTO, we really focused on public-private partnerships because we feel that that's a way, instead of reliance on federal funding, to support all this work that we're doing. There are opportunities to leverage that public-private partnership to create these sandbox environments, to look at data that public health may not have had access to, and how do we leverage these emerging technologies to be able to provide those insights to understand what's happening in the community. So the sustainability, I know like from an IT perspective, right, they're going to say, how can you sustain this? What funding do you have? And so if we can start to explore those ways to diversify that funding, not an easy thing to do, but how do we do that moving forward in the future? I think those are some of the things that are top of mind for some of the jurisdictions.
Let's definitely move into the question of resources in a minute, but first, Jim, your thoughts about what the sort of obstacles are beyond finances, let's say, that are coming up as people's concerns with regard to AI.
Sure, beyond finances, and I echo everything that we just said, but the main thing from my perspective at the health department really is the education and the training and being able to wrap this into a nice package for our staff. You can't do it in a nice package right now because we're still trying to figure this out. And one thing that we are actually using is Microsoft Copilot. So that is something that is now available to our staff at a county level. So the health department staff are trying to understand how to use this, and while senior leadership and others within the management layer are trying to also understand, well, how do we coach and train and educate for the effective and appropriate use of these tools that are now available to them. So that is a bit of a challenge right now in trying to figure out the best way forward to train and educate and help our staff. Now, in addition to that, I would say a little bit to what Tabatha was pointing out in terms of the interoperability or lack thereof. I think trying to figure out the best way forward to understand amongst the different institutions at the state, let's say in Virginia, how do we move forward with regards to understanding what is appropriate from a particular institution in, let's say, southeastern Virginia compared to where we are in the county up here in northern Virginia, and sharing that data, and so that the understanding of shared knowledge and being able to move forward in a synchronized fashion that says, yes, we know how we can help our constituents across the state and share the data in a way that is going to help everybody. That is something that we're still, it's a bit of a challenge. So that's still something that's being worked out.
Let's talk a little bit about resources, because I think that's relevant as well. In terms of government, there's sometimes a gap between the encouragement to use AI and the resources available. So for example, federal agencies, including CDC, have been very enthusiastic about the adoption of AI, but that hasn't translated easily into sustainable resources, I think, at the local or the state level. And just in the last several months, CDC significantly reduced its AI unit so that they're fewer people, fewer contracts. And reflecting on the fact that the public health system is very uneven. There are wealthier local communities, less wealthy communities. There are states that have bigger budgets, states that have less budgets, fewer budgets. How do you think about that? I mean, I don't know whether or not, you mentioned co-pilot, but I don't know whether the same involvement of the leading companies in AI have been engaged with public health as they have been with the healthcare sector, where there have been lots of new tools and developments. So are you finding that resources are a major issue, and are you concerned about the unevenness or the double standard that might exist as we look across the complicated public health system?
So, two aspects to it. In terms of the partners, the vendor partners, there isn't really a very mature public health focused AI, let's call it enterprise solution that's available, right? So most of the vendors, from Google to Amazon to the consulting companies such as Deloitte, Accenture, their best proposal is we'll develop one for you. And that is going to take time, and the more time you take thinking about it, talking about it, the less are the chances that you're going to actually get it done. So that's problem number one. Problem number two is from a resource perspective, keeping the initial investment very low helps you get that project started. And that is precisely what we're doing right now, is negotiating with vendors to come up with a product where the initial cost of the framework is very low. And then we co-locate and we co-create the tool through a few iterations where the State Department employees learn how to code LLM along with the vendor. And this has to be upfront with the vendor, and then you organically grow the strength and skills within the department. That way you're not dependent as much on grants, you're more dependent on general funds, which is more sustainable. And now you have skill set inside the state agency to develop further features and functionality. So that's kind of like the approach that we're taking.
Great, thanks.
I think to a certain degree, we're doing the same thing that Arman just mentioned, but at a much smaller scale. We're definitely, again, as I mentioned at the top of the panel here, that the exploratory phase that we're taking is more methodical. It's a slower approach. So we're being very strategic in how we're moving forward. So in terms of partnering with any other additional vendors, we're going to look at the most appropriate way to do that in terms of being able to get who we need to support our efforts. So it is definitely something that we're looking at, but not entirely there yet.
And I would say the kind of the outlet or the avenue for some of that information sharing too occurs within the peer networks and along with learning communities, where members are bringing together what they've learned and how they've been using AI. And you could see from that it creates and generates some ideas. And I know every jurisdiction is going to have a different type of policy, but then having to say, oh, how did that work? What tools did you use? What agreements did you have in place? Like, how did you address the privacy, the concerns around security and all those things? I think the more that public health agencies are speaking about that, it gets us farther along. It's still a process, right? It still can take time for that type of implementation, but I think we're headed in the right direction in trying to explore that. And we always talk about this, like public health has been delayed in adoption of certain technologies and things like that over time. And so I think we're really trying to observe, but also engage and to activate some of those things. And I think having environments where you can be more secure and you can test things out to see how it works gives also an opportunity to explore that. In the past, there have been advanced practice centers and the such that served as these playgrounds for like the syndromic surveillance when that was coming about, when we were, had an opportunity to say, what are these signals, and are these signals legitimate signals, and how do we refine, and it's like with AI, training the models, how do we better work with the technology to be able to leverage the technology.
One more question before we open it up to the audience, and that is, you've got folks here from the schools of public health and other schools of higher education. As you're thinking about what you'd be looking for, what skills would you be looking for in new graduates if you're interviewing them related to AI? How would you describe that? Is there a level of complexity that you would expect? Would you just expect them to be comfortable with AI, or do you think everyone would look to the newest hire as the person who's going to be the one that can help navigate the waters of the adoption of AI?
I think from my perspective, to the college here, you have to be open-minded, right? When you walk into public health, and especially in the AI front, out-of-the-box thinking, you have to be bold and brave with your ideas. You have to worry less about technology. Of course, if you want to be if you want to go in the technical field, perfectly fine. But if it's on public health side, don't worry about the technology as much. There are plenty of tools and skill sets available. But that out-of-the-box thinking, thinking through the lens of the community, thinking through the lens of what helps the public, that helps the information technology departments a lot. That partnership becomes very powerful. When you have the information technology department, and let's say epidemiology, or any other department within the state or outside the state, that is kind of what it takes to make something like this happen. So I would say that embrace it. Embrace it. Don't worry about the skill set, but embrace it.
So it sounds like you're saying, don't look at narrow technical skills.
Correct.
Look at the ability. Look at a well-rounded students. Let's say they can work with communities, that can interact well with other workers, but also have comfort with technology.
That is correct.
Got it. Thanks.
I would second that. Definitely be open, but don't lose sight of your core competencies in terms of public health and what you really need to hold on to in terms of your knowledge. Coming out of your learning phase, you're going to be going into a new learning phase when you hit the real world. And so with AI, what we're looking for really is to have that experience, having used the tools already, and to be able to speak AI literacy. But you don't have to have that full, complete knowledge of what the ins and outs are, of what supports the technology and how it works, but to be able to use it in a way that will help you advance your core competencies, and then be able to speak the language of public health in terms of how we're going to advance and improve our decision-making process, and be able to use and leverage AI as a tool, and then be able to effectively move forward in a much better way, supporting the communities that you'll be working in. So that's the lens that I'll be looking at.
Yeah, I really like those two responses. I could have said it better. I think too, it's nice to really have. There's a lot of change happening, so I think change management, being open to the idea that not everybody's going to feel as comfortable using AI, but what you can bring to the table might help to educate others in the use of that. So I feel like it opens opportunities. There's an opportunity to be innovative. There's opportunity to understand. I think data governance is really, really key in understanding how can you leverage and use data, but what are the different tools? I remember when I was in my doctoral program, one of the professors had long time ago said, you want to know the different methods and decide which of those methods or tools to use, and what are the pros and cons of those, right? Like, so what are the benefits, what are the limitations? And I think that's empowering us to be critical thinkers about when is the best time to use this. When you see outputs, sometimes you're going, well, that doesn't really add up to what I know, like in terms of like that depth of knowledge, and then you can say, okay, let me tweak that a little bit. Like, this is a good starting point as it continues to evolve. I think having that understanding and having that foundational understanding of the public health principles, of those key competencies, are going to be really, really key.
Thanks. So I think we want to open it up now for questions or comments. The mic's coming to you.
Thank you so much. I'm a Professor Daniel Choi for George Mason University. As mentioned, that the moderator question, that was I've been writing beginning of that, and you asked the question exact, because as a supplier or educator, we we would like to produce the competent, the public health students to the industry or as a practitioner. So I asked the AI some of the questions, same thing, and then AI provided different levels. Level 1, AI literacy. Level 2, so applied AI use. Level 3, advanced competency in there. So if you're looking at that as you do the job interview for the just new grads, say undergraduate students, for example, what types of levels would you look for that, first question, would you even ask an interview about AI question when you do try to hire new grads? B, if you do, how much of a levels of competence would you look for? So thank you.
Please.
Great question. I was immediately thinking about the interviews I've had recently, and I haven't actually asked that question yet. And so it's definitely something that I will be looking at in terms of where do you come from in terms of that perspective? Tell me about that knowledge that you've gained in school. Can you adapt and adopt any of that? Tell me how you're going to do that. So I would definitely say yes. And to what level, I would not necessarily look for like a very high, extreme knowledge base, but more of an understanding of the AI literacy that you mentioned. Is there some AI literacy that we can work with? And I think that would be better than none. And I think that's the key is, did you get anything out of your education that helped you with regards to the future of where we're going with AI? That's more or less what I think I would do.
And just to clarify, the position you're talking about is not a full-time data expert position. You're talking about the non...
Great point, John.
Yeah.
Yeah, exactly. Yep. The non-technical.
Yeah.
Let me just add to that. So being part of the executive leadership team, I do get to attend lots of interviews, and we actually recently interviewed a few key people in population health. No, AI was not a question. From my point of view as the interviewer, I'm looking at whether this person is going to work with me and collaborate with me and partner with me. All I need to know is what outcomes are you looking at? What do you want to do, right? As long as those outcomes are clearly defined, you have an information technology department that will help you get there, right? So, of course, it's very helpful to be aware of information technology processes and principles at a high level, the different types of AI towers like generative and predictive. But do you need to know anything beyond that? I think the answer is no, as a public health official.
Any additional thoughts, Tabatha?
I would just say upskilling. For those who are currently in the workforce, there's so many opportunities to upskill, so that's an area. So I feel like kind of like what you were saying, Arman, it's like the real focus here is kind of like your receptivity, your approach, that kind of like that. Are you able to discriminate in terms of like when you're using the AI, how would you leverage those? I think the trainings that are going to happen in jurisdictions are going to be really helpful when they get to that, because that's one of the key areas that we saw as an area for growth is training. So I would say, I imagine as time evolves, if you have different types of positions, maybe non-technical or data analysts or EPIs or things like that, it's going to be different types of questions for what software and things that they can leverage. So I think it goes both ways. Depends on the job.
Great, thanks. Ed?
Yeah, so I actually want to stick on this question of AI literacy, and maybe putting you all on the spot a little bit. So the current MPH foundational competency is focused around data. And right now, some folks are struggling even with should we be teaching R and Python and these tools, and is that considered AI literacy? So can you talk a little bit about, will we shift right? And if we do, at what point do we say in the classroom, well, you need to put your calculator away because you really need to know how to manually solve for whatever statistical evidence, so you can tell the difference between what's right or wrong. Can you talk a little bit about that and what would it actually look like?
So Ed, if I understand your question correctly, in terms of the competencies from a public health official, right? I think it helps to know Python or R to be able to look at data. But the key is to be able to communicate to the people who will execute that thought, what the thought is, right? And if that means that you know how to write Python and collect a set of data and say, hey, here's a set of data, and this is what I would like to do with it, great. Then learn Python. If it is that, hey, I already know what outcomes I want, can I borrow one of your guys to kind of pull the data that I need, and then this is what I want, that will work too. So I'm not sure if I answered your question, but it just depends on what the person is looking for and where that person wants to go.
I would say, Ed, it's probably more about a question about whether or not they are comfortable explaining what they know and whether or not they can put away the tool and speak to it anyway. So I think there's, and if I'm hearing you correctly, it's like, do we get to a point where you have to just say, no, you need to still be able to have your critical thinking skills and be able to determine what needs to happen without the tools, but if you know or happen to have the skill set for as a coder or a programmer, what does that mean for us in terms of the utilization of that? And so if it really depends on the person and where their comfort level is, but I guess you can't expect everyone to be at the same level and be able to speak to the same degree of experience and knowledge if you are going to be in a particular role versus another role. So it's a hard question to answer, I think, because we're not quite there yet, and so things are still evolving. But I would say that in the future, we're probably going to be in a position where the people that are really going to dive deep into this technology are the ones that will expect more out of other people because they know what the future is in terms of capabilities and the applicability of features and the way that you can code and program things with the use of AI. But if you haven't heard, vibe coding is something that is out there now, and vibe coding can help you become more of a knowledgeable person in terms of coding if you never learned R or Python. So those are things that are evolving right now. So I don't know if I answered your question, Ed, but it's a great question.
I think it's a difficult question. This is more from like professional experience. I think when you're coming out, with like an epi degree or something like that, they'll say, "Oh, have you used SAS, like R, Python, whatever that is?" And it's evolved over time. I remember one of my mentors, like he practiced public health in the 80s. And he was like, "You're more of an epi because you can do data analysis with SAS." And I was like, no, that's not the thing, right? Like like during the pandemic, he contributed so much. He wasn't doing the data analysis, but he was able to provide other insights. So I feel like it's the tools that we have now are going to continue to evolve, whether it's Python or it's going to be some other AI tool. So I feel like it's training code, or you could write code for like SAS or whatever that might be. I think that gives you the depth of understanding of what's possible and versus somebody that may not have that experience. So you can come in, it's not necessarily transferable like Stata and all the such, but they're very similar, right? Like in different ways. I think that can translate over. I think it's being trained a skill set to say that I can learn this, I can leverage that. I would say what we did a lot of was data validation. So I give my data to the vendor, they're gonna populate our public facing dashboard. Okay, we're gonna behind the scenes, like we're running SAS code to make sure that those two numbers are matching up. Okay, you guys got it, we're done. Like once it's validated, we transition over, we may do some spot checking and things like that. But I feel like it's kind of like that with AI or other tools. You wanna make sure that you're validating the content, the technical components of things to make sure it works. And then you do these routine kind of like checks to make sure that everything is running the way it needs to run. Something in the code didn't change, or we're detecting something that changed, but is it true change, or is it because of something that happened happen from the data source. So I think from the perspective of understanding the way the data are generated, like the data generating mechanisms in place, I think that's important. When you get the technology, the technical solutions, that's the other piece of it. And then it's looking at the content and testing that and making sure that makes sense, like from a human perspective when you're looking at the data. So it's like that's like informatics, like from like start to finish in terms of like more of, not the IT part of it, but more of going through and working with the program staff and making sure that things add up. So whether that's using those tools, software or not, I think eventually, yes, today that makes sense, but it might change in 5 to 10 years, and programs are just have to adapt, I think, to the changing and being responsive to those changes and kind of scanning the workforce. Like for you all, I don't know if you use Python or SAS or SPSS or Stata or whatever, but all of those are tools that are used. Even Excel is used in some jurisdictions, but that may not be able to afford some of the other types of tools that exist. So I think it goes from different levels.
The other thing I would add, in my experience, is we're looking to graduates, I think, as having good critical thinking skills and good listening skills. Because a lot of times what can happen in an agency level is you can have the tech people over here and the program people over there, and they don't communicate well with each other. And the starting point should be, what is the problem we're trying to solve? What's the issue? What's the health issue that we're trying to understand better and get a handle on? And that often is not initially a technical question. That's initially a strategic thinking skill, like what's our priorities here? And then the question is, is there technology that can help us in terms of focusing on that? But I think what we're all saying is we don't think it's good to have narrowly trained specialists. Ideally, we want people who have the ability to communicate across technology and across programmatic areas with a certain degree of expertise. Ed, does that make sense?
I think so.
Yeah.
I agree. No, I was just agreeing. Yeah, definitely.
And
Please.
the ability to articulate the problem and how, from a business point of view, what can we do to solve it? I think that's the key.
I'll just give you the example when I was at CDC. So CDC, absolutely people wanted interoperable data. They wanted all of CDC's databases to be easily interoperable. And that people could understand that made sense, because then you could have a report that would come out that would look to all of the different databases, and you get a really well-rounded picture of the health of a population. The main obstacles to that happening weren't technical. The main obstacles were that people were protective of their databases, and that they really felt like, you don't understand what my field needs in terms of addressing a particular health issue. So a lot of the skills that people needed in terms of moving ahead with that goal were really understanding, what are people afraid of? What are the people who run a database, a particular database they've developed over years, afraid they will lose if everybody's in the same data lake and you're using consistent questions? So that's really that's a different set of skills, and you have to peel back the onion, I think. But I think still at CDC that's a big issue. People want interoperability, but they really don't want to give up their ownership of the way they've done things.
Hi, everyone. Thanks for
Hi.
a great conversation so far.
Thank you.
So I'm hearing from the VDH and the FCHD side that you guys are kind of putting that infrastructure and that guidance in place, and that's the stage you're at right now. But I'm curious, going back to this concept of the democratization of data and ways that we can do that, in the real world, on the ground, once this infrastructure is all kind of figured out. I work heavily with safety net clinics and CBOs across the county and the Commonwealth. So I'm curious, some of those real case uses, I'm thinking of these changes to Medicaid coming up in the fall and into next year, and the data sets that both of your organizations have. Would that be maybe not for this particular iteration of changes, but would that be something that you all would see coming together and using that AI as a tool to be able to impart that information of who's losing coverage and things like that? I'm just curious what sorts of ideas might have come out of your brainstorming sessions so far.
Yeah, excellent point. Thank you. So, two things. one, with respect to democratization of the data and how we do the right thing in order to help those who need our guidance, VDH, Fairfax County Health Department, we will work together and try our best. And this is, with my full understanding that there are ways to do this correctly, but to work together to make sure that we use and leverage the tools that AI are making capable features for us to use in a way that will help, I think, catapult us to that next level of sharing data. Because the bottom line is it is so important to make sure that we are doing the right thing and leveraging these tools to help those who need our guidance, support, and to help make the decisions to help those. Case in point, the rural communities that are probably still lagging in terms of technology and connectivity. Those are things that, just recent legislation has, allowed and enabled vendors and corporations and institutions to move in that direction. They've been lagging for so long. I mean, I remember, for more than 10, 12 years ago when the electronic health record was still paper. and the advancement of technology that helped bring things and move forward, it still left others behind, unfortunately. So I think we're in a critical state right now where we need to leverage the technology, and between the state, the Commonwealth, and other counties, not just Fairfax County Health Department, work together quickly to understand how we can use the tools in order to share the data in a way that's responsible, safe, secure, and bottom line, help those that need the help. So I think right now, this is the opportunity, and an opportunity has been brought up many times today so far, and it's a huge opportunity right now for us to not miss out on. And so I don't know if Arman has anything to add there, but I know that we'll be working closely together to figure it out.
Yeah, I mean, I agree with everything you said. And, look, there are also structural problems, right, within the state of Virginia. For example, when I share data with DMAS, right, do we have a data sharing agreement? It's a structural problem. We don't. And we do, but for this specific set of data, but we don't for that specific set of data. So what do? You have to come up with a standardized data sharing agreement, not just with DMAS, but with other state agencies as well. But we don't have a central body that spearheads that effort. So some agency has to step up and say, all right, I'm going to take charge to have a standard data sharing agreement, because you can't really give data without having an agreement in place, right? So those are some of the structural issues that we are working through. And work gets done, don't get me wrong, work gets done. But when a big initiative like the Rural Health Transformation Program comes in play, suddenly we're like, okay, we need all this data, we need to share data. Oh, by the way, we don't have a data sharing agreement. So let's get back to the table, draw it up, let's see what we need to do. And we already talked about the infrastructure. I think we're a long way, where we were 5-10 years ago. Like we have, fully electronic health record that we are implementing right now in the state of Virginia, and that's going to give us a tremendous amount of data. So a lot of good things happening, but as you said, that these instances, events, are opportunities for us to always take us to the next stage.
Maybe I'll ask one final question about the future. We've talked about where you are now and what some of the obstacles are, how you're working to overcome those. Just this is a lightning round answer. If you're thinking 2 years, maybe can you think beyond 2 years from now, 5 years from now, what would you hope the AI use will be in your agencies?
I'm not going to hope. I know that 2 to 5 years from now, we are going to have a significant presence of AI in the state of Virginia, because I'm rooting for it. We have to go through the challenges not challenges, but the process through VITA, which we have already started. But, to not do it, in itself is unethical. I don't know how else to put it, right? It is such a powerful tool. in all aspects, not just public health, but workforce optimization and admin operations, and the ability to serve the citizens of this state, right? The citizens of this state in a very meaningful way, whether it's public health or community worker. AI is going to become very important. It's efficient. So yeah, 2 to 5 years from now, absolutely AI has a very strong presence. Plus, we should be able to get to a stage where we are now predicting disease outbreaks and things like that. So that's my prediction.
Thank you.
Yeah, I would say that it would, for me, I think the Fairfax County Health Department will see itself in a completely transformative way, helping its constituents to live better lives. And ultimately, that means that AI is going to be a tool and a mechanism for us to achieve that faster, sooner than what we ever thought was possible before.
And I think what I'd like to see is that we have really these success stories, opportunities to learn from each other through like the peer networks and learning communities, and where we can have use in public health that are governed, that protects the data, the privacy, security, that's all in place, and we're able to leverage all of that so for some really innovative insights into the data and more importantly into our communities, so that we're actually starting to leverage that those tools to change and improve the health of the people that we serve.
Well, great. Thank you for that vision of the future. The students are graduating. They'll be part of, I think, that vision. So please join me in thanking the panel. So.